welcome to day 2 of the annual European Rheumatology Congress here in Madrid, where it's still very sunny. We're on day 2 of the conference. Thank you very much for joining us here on Eular TV. I'm Mrinalini and I'm an academic rheumatology trainee in Liverpool in the UK, and I am still joined by Stephanie.
Hello, and I'm Dr. Stephanie Shoot-Borrell, and I'm still a research associate in epidemiology at the University of Manchester. I'll be covering your paediatric highlights today.
Wonderful, thank you. And today we also have with us on Eular TV a third young rheumatologist reporter, Mikel. Where were you yesterday, Mikel?
Well, Mrinalini, it was a very tough decision to be on the scientific sessions instead of being here in the studio with you yesterday. But yes, I was on the sessions, and I will cover this later on in detail. So, and my name is Michail. I am the rheumatologist in training and the researcher from the Charité Medical University, Berlin, Germany. And we are very lucky also to have a guest in our studio who is the rheumatologist from Portugal. His name is Santiago Rodrigues Manica. Thank you, Santiago, for being with us today.
A warm welcome, and also a warm welcome to Miss Indra Beer. Welcome to Eular TV.
Thank you for the invitation. Hello.
Thank you very much to all of our guests for joining us today. We've got a lot to pack into today's edition of Eular TV, so hold on tightly to your seats. We're going to be covering paediatric rheumatology with Stephanie. I will be talking a little bit about Behçet's disease and a rheumatoid arthritis and fatigue session I attended, and Mikel will be covering spondyloarthropathies. Mikel, do you want to tell us a little bit more about what you have been to over the last 2 days?
Well, with pleasure, Mrinalini. Indeed, I have attended yesterday and today the sessions devoted to the axial spondyloarthritis and also to the psoriatic arthritis. So the first session was named the best practices in the SPA, and there were 3 brilliant reports wrapping up this session. So the first one was delivered by Dr. Victoria Navarro-Campan, telling us about the appropriate use of the non-steroid anti-inflammatory drugs for treating patients with the axial spondyloarthritis. It is well known that those drugs are the first line of the therapy, and to consider other options, patients with the axial spondyloarthritis should not respond at least to 2 drugs of this type. And it has been confirmed during the lecture that there is no preferred drug from this group to treat the patients with the axial spondyloarthritis. The majority of them, they are comparable in terms of the efficacy, but one would need the individual approach to every single patient to prescribe such drugs because of the differences in the safety profile. And the disease-modifying effect of those drugs still remains controversial, and for this reason they are indicated by demand, so to be administered mainly and generally in symptomatic patients with the axial spondyloarthritis. The second report was on the treat-to-target strategy, which was delivered by Dr. Pedro Machado from Great Britain.
Can I stop you one moment there, Mikel? Would you take us through what treat-to-target actually is?
Well, generally this is the modern concept which is widely spread nowadays in the whole area of the rheumatology and also in the area of the axial spondyloarthritis, telling that the treatment, active treatment, should continue until the pre-specified target will be achieved. And this target usually will be the remission of the disease or the condition when patients with rheumatic diseases do not have any significant clinical manifestations of disease, or the condition which is called low disease activity, which can be defined and measured differently. And this is also the area of the discussion in the axial spondyloarthritis, because those targets, they might be just differently defined. This is one problem, and the other problem is that it seems to be that this approach, treat-to-target approach in axial spondyloarthritis may work, but generally speaking, we generally have only the results of the observational studies confirming that. And this knowledge gap is the question to be answered soon, because at least one study would be addressing this question, and the results of this study, which is called TICOSPA, are expected to be issued and published in 2020. So soon we will get the answer on this question. But nowadays there are already recommendations of the treat-to-target approach that were published pretty recently in the Annals of Rheumatic Disease. And the third abstract that I would like to highlight, this was the work performed by Dr. Uta Kilz from Germany, who was reporting about the quality standards initiative in the area of the axial spondyloarthritis. I was lucky enough to be able to interview her today early at the morning, and I can happily pass the word to her personally.
The ASA's quality standard project is important because quality of care improvement has become a priority area, not only for physicians, but for patient and decision makers as well. And to be able to quantify quality of care improvement, it is needed to have a quality measure. And this quality measure didn't exist for patients with axial SPA. It's important to understand that there are differences between a quality standard and recommendation. Quality standards really quantify in a measurable construct domains on topics where there is variation in care, whereas recommendation normally try to describe and to recommend at each different stage of the disease the different treatment options. The key areas for quality improvement were identified by the committee member of the ASA's Quality Standard Group with support of healthcare professionals and patients, as well as the ASA's community. And I would like to highlight during this talk two main key areas for quality improvement, namely the referral quality standard and the inequities in two treatment options. The referral quality standards are divided into two quality standards. One is addressing the GP area and one is addressing the rheumatologist, and is saying that the GP should immediately, within 3 working days, refer the patient with suspicion of axial SPA to a rheumatologist. And for the rheumatologist, it said that the rheumatologist is having 3 weeks time to see a patient with a suspicion of axial SPA. However, this timeline might be very ambitious for worldwide for many countries because of the reduced numbers of rheumatologists in these countries, as well as restricted access to specialists. However, the aim of quality standards is to have a measurable construct and also to explain why rheumatologists need more resources to see all patients with suspicion of rheumatological disorders. Also, the key area for quality improvement in respect to treatment option is a barrier for many patients. The most prominent example is the inequity regarding access to biologics therapy, and we clearly state in this quality standard that in patients with high disease activity, despite conventional treatment options, access to biologic treatment is discussed. However, also here decision makers have to check these quality standards to see whether there is room for improvement in this area worldwide. We hope with this project that quality of care improve during the next years, and that we will be able to measure these quality improvement.
So, methodological concepts in spondyloarthropathies are very important, as we've just seen, but classification in spondyloarthropathies are also a hot topic at the moment. Mikhail, do you want to tell us more?
Well, yes, it is correct that there are certain issues with the classification and the peculiarities of the classification in the area of the axial spondyloarthritis, and this is linked to the fact that we actually have two actual sets of the classification criteria. One is for the condition which is called ankylosing spondylitis, and the second one is for the condition which is called axial spondyloarthritis, and there is a subgroup of the axial spondyloarthritis which is called radiographic spondyloarthritis, which is pretty similar to the ankylosing spondylitis, but those concepts do not completely overlap. So, and the key question in this area was whether we can use the old data that were collected using the old classificational criteria for the ankylosing spondylitis to compare with the modern data that are mainly collected using the new axial spondyloarthritis classification criteria. And the report of the Anne Boeien from Netherlands covering exactly this question, and I also happily passed the word to her as we did the interview yesterday.
We looked at the overlap between the modified New York criteria and the ASOS criteria for radiographic axial SBA to see whether these two classification sets actually classify the same patients. And the overlap was actually really high. So yeah, why it's important? It's important because there's an ongoing debate whether they can be used interchangeably or cannot be used interchangeably, whether they actually classify the same patients or whether the patients are different. So the reason we did the study is to actually see whether they were the same. And as it turns out, they actually are in the biggest part, because actually 93% of patients classified by the modified New York criteria are also classified by the ASOS criteria for radiographic axial SBA. And if we look the other way around, then 96% of the patients classified as radiographic axial SBA by the ASOS criteria also classifies according to the modified New York criteria. I think they both have their qualities, and I think both can definitely be used still, because it also depends on the context in which you use them. For instance, for clinical trials, sometimes the inclusion and exclusion criteria are stricter, or the pharmacy may prefer to use the modified New York criteria. So I think they will still both be used in practice or in research, but I think it's important that we now know that it doesn't really matter as much because we capture pretty much the same patients.
Another highlight from the same session, which was called Spondyloarthritis on the Move, was the report by Dr. Renson from Belgium, who observed high prevalence of the inflammatory lesions that can be assessed as the lesions typical for the axial SBA in a population of the healthy postpartum women. And surprisingly, up to 80% of females who just delivered during the last 10 days had the typical inflammatory lesions in the sacroiliac joints that can be potentially misclassified as lesions typical for the disease. And almost a half of those patients retained those lesions after 6 months of after the pregnancy. So those findings should be interpreted with the caution not to overdiagnose the axial spondyloarthritis in postpartum women. And the third highlight of the session was the report that was produced by Santiago Rodrigues Manica from Portugal. And we are happy to have him here today at the studio. Hello, Santiago, and thank you very much for being able to join us. So you have reported about the progression of the structural changes on the MRI in patients with axial spondyloarthritis. Can you please tell us shortly why the structural changes are generally important for the patients with the axial spondyloarthritis?
Well, regarding structural damage, this is a very important hot topic in axial spondyloarthritis because it will lead to functional impairment and to daily impairment of the patient, affected their quality of life. However, we went some steps backwards, seeing the factors that will lead to this structural damage that can be assessed in imaging. It's already well known that local inflammation, so-called bone marrow edema, so that's the term, will lead over time to this structural damage. However, there was a gap of knowledge that this study tries to fill, because we look at smaller units. So we look at the so-called quadrants, and saw that local inflammation in one quadrant over time led to structural damage, explaining some steps backwards of this very relevant phenomenon.
So literally you have shown that the inflammation in a certain point will likely lead to the development of the structural damage at the same point where the inflammation was previously.
Yes, regardless of disease activity or treatment, it's a local inflammation driven process.
Yeah, and how can how the findings can change the approach to the patients with the axial spondyloarthritis?
Well, that's a really tough question, but not the approach to treat to target. Of course, I don't have a plain answer, but this can alert the clinician to take into consideration also imaging findings of local inflammation into their clinical decision to avoid structural damage and functional impairment, and improve the well-being of its patient.
This is crystal clear, Santiago, and thank you very much for being able to join us and to share the key points of your abstract with us on the Eular TV.
Thank you very much for the invitation. It's my pleasure to be here with you today.
So we continue with the highlights on the psoriatic arthritis sessions that were performed today, early in the morning, and there was a number of the reports telling us about potential new treatment opportunities in the area of the psoriatic arthritis, and namely at least 2 new drugs, pimekizumab, which is the interleukin-17 dual inhibitor, and filgotinib, which is the JAK inhibitor, were proposed, and the results of the stage 2 and 3 trials were presented during the conference, as well as the results from the stage 3 trial on the ixekizumab. This drug is already registered for the treatment of psoriasis and psoriatic arthritis. What is important to say is that all of those drugs really showed very good results in the treatment of psoriatic arthritis with the ACR20 response. This is one of the typical parameters that assess the efficacy of the drugs in the psoriatic arthritis, achieving 80% in pretty much all of those clinical trials.
Thank you so much for that, Mikhail. And it's so interesting to hear about these biological DMARDs in adults, because of course both biological DMARDs and synthetic DMARDs are very common among pediatric patients with rheumatic diseases. Now, I was lucky today to hear Dr. Veronica Bogonzo from Israel talking about the use of these drugs alongside vaccines and whether this is a safe option. Now, we know that adults on these immunosuppressive drugs are advised not to vaccinate with these live attenuated vaccines. And it's a big contentious issue right now in children. So in children, we worry about infections and flares when we combine DMARD drugs alongside these attenuated vaccines. And we saw a study where she collected data from 10 countries, with the majority of patients having JIA, but also we saw some patients with JDM, uveitis, and other autoinflammatory conditions. Now, her main message here, and you can relax at home, these vaccines are safe. They're safe in these children with these multiple conditions, even alongside drugs such as methotrexate and these biological drugs. She saw very few adverse events, 3 in 100 on methotrexate and around 7 in 70 on biologics, and these adverse events were all mild. So we saw just local skin reactions and fever only. We saw no flares of the disease and no infections related to the measles, mumps, rubella, or measles, mumps, rubella, and also varicella drugs. So that's our story for children here, but as children grow older, they may need to consider transferring on to adult care. And we're very lucky to hear today to have Miss Indra Beer from Germany to talk to us about transfer of care. So Indra, what's your experience with JIA?
My experience with JIA started when I was 13, and I had a sport accident and have an injury in my knee, and first I think it's a normal injury, and then I go to the doctor because I have a big inflammation in my knee, and then he told me, oh, maybe it's rheuma, it's a rheumatic disease, and I have luck that he said that, because then I get fast to the Paediatric Rheumatologist, and he offered the diagnosis. Yes, it's right, it's rheuma. And yeah, my experiences are I have some positives and some negative experiences. And first of all, I can say that everything is possible with this disease. And yeah, one positive experience is with friends when I communicate that I have this disease, and at days I cannot do everything. They say, oh, okay, we feel with you, we understand, and we help you. And that's very positive, because you know, your friends are the right friends, and you're welcome there. And but I have a very big negative experiences with the disease. When I was 18, I have a big flare-up, and I can't walk half a year, and have inflammation in whole of my body. And that was the time I started my first job, and I started my first job 2 weeks later. I get ill for a long time, and so they don't understand what is rheuma. Rheuma is a disease of old people, not of young people. And yeah, at the beginning, when I started my job, nobody has seen that I have a disease, and I don't communicate it, because I don't know why I should do this. And yeah, it was not so positive as when you get this feedback.
Gosh, I'm so sorry to hear that. And of course, when you were 18 then, it was time to move from paediatric to adult care. And what was your experience of that?
Yeah, I had hard experiences with transition, because I don't have a really normal transition like the right way. That's because I got the diagnosis when I was 13, and I told you that it was very fast. Then I get the diagnosis, I get my medicine, I get my pills, and I feel very good after maybe 3 or 4 weeks. And I have no symptoms of rheuma, I have no hurting, no inflammation. And yeah, when I get older, maybe 14, 15, I want to be a little rebel and don't want to be a human with a disease, and my head was full of everything else than transition or medicine or rheuma. And so I don't take the pills, don't go to the doctor, and because my parents say, oh, you're healthy, maybe you don't have rheuma anymore, or they hope so. And yeah, then when I was 18, I have to pay the bill and go to another doctor then. And so I don't really had a transition, because nobody told me about that, and I don't want to think about my rheuma when I'm healthy and feel good. And yeah, after that I learned a lot about the disease, and what I have to do, and yeah, what damage I have from this rebellion.
I'm so sorry to hear about that experience. And what do you think we can do to help make the experience better for young people like yourselves who are going into adult care?
Yeah, I can recommend 2 things to you. First of all, don't look at the disease of the people. Look to the young adult as a normal young adult, and yeah, don't see only the disease. And the second very important point is to understand the young people, to understand that the head is full of friends, party, move out, first relationship, and not full of rheumatic diseases. So the best thing is when the parents, doctors, and healthcare professionals think about their puberty and think, what was in my head, what I wanted to do in this time. And I think that's a good way to understand them, and to start the transition process not as an event when the child is 70 or 18. Start the process a few years ago, step by step. Start to talk about you have to do this in the future, and maybe ask what they want to study, or if they want to go to another city. So plan this, because then the young people know, okay, there's something coming to me, I have to do, and I have to know about my disease, I have to communicate it. And a good recommendation to the parents is that they have to talk to the child, that the child have to do something on their own, go to the doctor, maybe with the parents, but the doctor have to talk to the child, not only to the parents. They can listen, but they, don't be so, don't be their managers.
Thank you so much for that, Indra. Sorry, Mikhail.
Yeah, can I also ask you a short question? Now, with all this story behind your back, you are either optimistic towards the future or pessimistic because you have the disease. What's your feeling about the future?
I have an optimistic feeling about the future, because I told you about my experiences, and I have positive and negative one. And when I'm started to wanted to know about the disease, I read a lot and go to congresses and be active at the Rheumatology. And then I heard about new medicine, and I know, okay, with this things I can live a long, very healthy life, and I do something against the Rheuma, I do something like sports, so I'm not afraid about my future. And I have another positive experiences when I have a job interview and I communicated open about this disease and about my volunteer work, and they say, oh, it's not a problem, it's okay, everybody is ill sometimes, and so it's good that we know it and we can give you work you can do with it, and so that's very positive, so I have no fear.
Thank you so much, Indra, and I'm so glad that you have an optimistic view of the future now. But I'm sorry that you had an experience of transition that wasn't quite what you needed there. And in the same session that we heard Indra speaking in today, I heard from Dr. Judy Ammerman, who's a nurse researcher working in Utrecht in the Netherlands. Now, Judy was talking about these new e-health interventions to help young people go through the transition process and transfer from pediatric to adult care. Now, these e-health tools that she had included videos, apps, and access for the young people to their own medical record. But the take home from that was, even with these new tools, for adult rheumatologists who are seeing young people coming into their practice, you need to not focus on yourself and what you want the patient to have in terms of the drugs and in terms of adherence, and to not phrase a session when they come in as, oh, how are you today? Instead, talk to them about their own priorities. The first thing you say as they come through the door, hello, and what's the most important thing that you want to discuss with me today?
Thank you so much, Stephanie, for that, and thank you to Indra as well. And patient priorities are very important, none more so particularly in rare diseases. And as if by magic, we have another guest with us. So we have Dr. Cassandra Buzata from who's a senior registrar in Romania. Thank you very much for coming. So Cassandra was very fortunate to receive a Eular scientific training bursary to come to none other than Liverpool, which is of course the best city in Europe. And she was doing some work on psychological factors in Behçet's disease. So we'll hear more about your work. You presented it today on a poster tour. Would you like to tell us a little bit about your work and about the cohort that was involved in this study in Liverpool?
Thank you for having me, Renalani. And I would like to talk about the experience that I had in Liverpool. For the 6 months that I spent there, I met an amazing team of people that were interested in giving patients also the medical support, but psychological support also, because they understood that's an important part of taking care of a patient. For this study, we had about 86 patients involved, both male and females, with a median age of about 30 years, but they were between 30 and 50, most of them, and a median disease duration of about 10 years. For each of these patients with completed activity scores, each of them rated their disease activity and completed scales for depression, anxiety, coping mechanisms, and illness perception disease.
Thank you. Could you possibly just summarise your findings from us from this study?
Yes, we found that disease activity was rated approximately the same by a patient and doctor, but were also differences, and also there was a high correlation with anxiety, with depression, with dysfunctional coping mechanisms, and we saw that the way a patient is rating his disease activity is a direct it's a direct predictor of dysfunctional coping mechanisms, and this is creating a circle that is influencing how a patient is feeling, his mood, and in the end how he is rating his disease activity.
Very interesting, thank you. And I also have a small question to you. Is it a depression due to the disease activity or disease activity due to the depression? What is your impression on that?
That's a very interesting question, and that's why we wanted to make this presentation, because we think that after giving a patient enough psychological support in order to be able to take out at least part of the depression, what you get out of it is the fact that you see if there is still a problem or it was the depression and a need to find other ways to cope with the diagnosis and your disease.
Thank you very much, Cassandra. Depression and psychological factors are a key thing to take into consideration when we are looking after our patients, and a further symptom to be aware of is fatigue. And one of the key sessions I went to today was on rheumatoid arthritis and fatigue. And as a trainee particularly, one of the highlights and take-home points for me was to make sure we are addressing this and working towards new trials in order to find out exactly what causes the fatigue in rheumatological disease and how therefore best we can manage it.
Thank you, Marlene, and it's been so nice today to be discussing so much patient-centered research.
Yes.
Yeah, and the question of the fatigue is really very important, and it is important not only in the rheumatoid arthritis but also in the other diseases. And unfortunately we already know that the fatigue and the response of the fatigue to the treatment doesn't always correlate with the disease activity, so it's really an emerging question, what can we do with this? So thank you for these insights.
Yes, that's an important point, Mikhail. Thank you very much. That's unfortunately the end of today's edition of Eular TV. Thank you very much for joining us on day 2 of Congress. Thank you to our guests as well, Cassandra and Indra, and of course Santiago as well. And we'll be back here tomorrow for day 3 of the Eular 2019 Congress. And we'll see you there. We're now off to the EmuNet dinner.